I'm Sukhjinder Nijjer. I'm a cardiologist working at Imperial College at Hammersmith Hospital. We'd like to reflect on situations of when iFR, which is a new technology, and FFR, which is a current established technology, what happens when they disagree? Why does it happen? What does it represent? And does it matter for our patients? Here in this slide, you can see that there are a number of different head-to-head comparisons between iFR and another parameter which typically uses a vasodilator to see if we're able to detect ischemia any better. In the first study, Sen et al., which was the Clarify study published in JACC, had a small physiological study of 51 patients, had patients undergoing iFR, FFR, and HSR, the hyperemic stenosis ratio, to detect, and using that as the gold standard, to be able to detect ischemia. And what we found was when we compared both iFR and FFR to HSR, which many physiologists believe is a true reference standard of ischemia within the coronary vessel, that there was no difference in diagnostic accuracy. In the second paper by Tim van der Hoof, compared intracoronary measures iFR, FFR, and BSR, the basal stenosis resistance, a technology that was developed by Jan Peek and colleagues at the Amsterdam Medical Center, against thallium scintigraphy, which is a commonly used test for cardiac ischemia, and we found that there was no difference in the ability to detect for ischemia against that particular gold standard. In the next paper, the data set analysed by Niels Johnson et al., which was published in JACC, took combined pressure and flow data and compared iFR and FFR with HSR again, the hyperemic stenosis ratio. And again, in this data set, which was larger than the Clarify study, twice as large, found that the instantaneous wave-free ratio actually had a accuracy for detecting ischemia compared to this other invasive measure. In the fourth paper, a recent publication by a colleague of mine, Riccardo Petracco, recently published in Circ Intervention and was presented at last year's TCT, demonstrated when iFR and FFR are compared to CFR, so an actual measurement of flow within the vessel, there was a stronger relationship between iFR, measured at rest, with CFR, measured under hyperemia, than was found with FFR and CFR. This apparently unusual finding will be discussed later, which will basically be able to demonstrate that when flow increases significantly, pressure gradients can be generated that occur only under hyperemia and not under resting conditions, but when flow is not actually limiting in a particular vessel. Finally, in an important study coming out of the VU Medical Center in Amsterdam with the first author Guus de Woord, compared both iFR and FFR against PET, which is considered to be a gold standard by many for the detection of ischemia. In this study, they used the latest techniques of PET to be able to look for ischemia, and they found that iFR and FFR had no difference in being able to detect ischemia, and they both had the same accuracy. So these are interesting studies that basically help us know that iFR and FFR have similar diagnostic accuracy for detecting ischemia when compared to another standard. This is worth remembering that FFR itself was compared to PET in a small study of only 22 patients, and then against other non-invasive tests like exercise testing and stress echo, many of which are now considered less accurate at being able to detect ischemia. So we should be aware of that historical knowledge when judging a new index. Here I'm showing a slide from Guus de Woord, who graciously shared this information with us following his presentation at the ACC, which demonstrates the relationship between PET myocardial blood flow and FFR and PET with iFR. And you can see here that the number of misclassifications for ischemia are 12 patients for FFR and also 12 patients for iFR. The relationships are identical and both significant on both sides. You can see that, therefore, there is no diagnostic difference in being able to make a diagnosis of ischemia with the use of resting measure like iFR or a hyperemic measure such as FFR. How can this be the case? Well, if we go back to early studies looking at myocardial blood flow, and in this study here published by Uren, Bernard de Bruyne and Kamichi, they assessed what happens to myocardial blood flow on PET imaging, and they measured flow at rest as well as on hyperemia. And in their study results in patients that had stenoses between 20 and 90%, they demonstrated that hyperemic blood flow is significantly larger than flow at rest. And this makes sense and is what we are very familiar with. We know that hyperemia increases blood flow. However, this finding is more than it first seems. This paper is very fortunate because it provides a great deal of the raw data within the paper itself. And if we tease the study apart and have a look at those stenoses that are less than 50%, we can see that it is these stenoses that predominantly have a large increase in flow, while stenoses that are greater than 50%, that is, stenosis that we are interested in as interventional cardiologists wanting to perform therapy for our patients or look for a lesion that's causing ischemia, we find there is actually no statistical difference between flow at rest or under hyperemia. So let's reflect on that again for a moment. Only in stenoses that are less than 50%, that is, the stenoses that are not important to us, had an increase in hyperemic flow, whereas those stenosis that were greater than 50% had no increase. The purpose of this assessment is to really say that there are differences between stenoses on whether they can increase flow or not. Very mild stenoses have the capacity to increase flow significantly, and so they should. They are not flow limiting. Other stenoses in which there is a limitation flow have no increase in flow, and therefore giving hyperemic agents shouldn't really cause any increase. This is intuitive, and really we have to ask, does this matter? Well, typically in the catheter lab, we are measuring pressure, and we are using pressure as a surrogate of flow. And if we look at these two vessels here, both have the same MLA. They both have the same reduction in the vessel's diameter at both A and B. However, if I was to ask you, which do you think is most likely to be significant on a pressure wire assessment, I would think that many of you would choose B, because intuitively you can see that the vessel is craggy, it is not smooth, and it is irregular. And in this situation, you can see that there is increased turbulence as blood is flowing through that small narrowing, and therefore there is a greater pressure loss, because separation losses are greatly increased. In the upper panel, the lesion is reasonably smooth, and therefore there is predominantly only friction loss of energy, and therefore a pressure loss may be smaller or not significant whatsoever. So we can see that the amount of flow that occurs across a stenosis is important, and is also important on how the stenosis appears and its other characteristics, such as whether it's particularly tortuous, whether there is any calcium, and whether there is any other more diffuse disease. This property of physiology was well recognised by pioneers in the field, and in this seminal work by Lance Gould, he described a number of pressure flow curves. In these curves, he created stenoses in animal models and measured coronary flow velocity and pressure in order to plot these curves for what he considered absent stenosis, mild stenosis, moderate and severe. If you look at the severe curve, you can see it's very steep. You can see that only a very small amount of flow elevation will cause a very significant pressure gradient or transstenotic gradient across the individual stenosis. If you look at the bottom line, you can see in the absence of a stenosis, there is still a pressure gradient, and that gradient will be elevated if flow velocity is increased significantly. If you look at that red dot, you can see that in this particular vessel, with no apparent stenosis, coronary flow velocity is approximately 30 centimeters per second. However, if we increase the flow velocity to a supranormal level, say along the lines of 100, maybe 110 centimeters per second, that there would be a very large pressure gradient generated. So you can see that it is possible to generate a significant pressure gradient in the presence of only a trivial stenosis but high flow velocity. You may see this in the cath lab yourselves if you were to take a pressure wire and place it in the LAD vessel of a reasonably young fit patient who has a normal myocardium, And if you were to give them centrally administered intravenous adenosine, you may get a very strong, large response to the adenosine, causing an increase in flow, provided their myocardium is normal. In this situation, where the flow may increase by several fold, they may generate a pressure gradient, even if there is no particular stenosis. In these situations, experienced physicians will have noticed their FFR values are not 1, but are closer to 0.9 or maybe even down to 0.85. Whereas in the past we may have considered this was due to diffuse hyperaemia that we can't visualize. If we go back to physiological principles, we can see that a pressure gradient or a reduction in a ratio can occur simply because of an increased flow velocity across a trivial stenosis. And this was well recognized by Gould in 1978. It's with this in mind that it's worth reflecting on clinical cases such as this one shown here, which has been presented on a number of occasions at both the ESC, TCTAP and many other international congresses. In this case, collected from a hospital in Central Europe, showed that there was a 67-year-old patient who was classed as having very atypical chest pain and underwent a number of non-invasive investigations. The resting ECG was normal. An exercise echo was performed and was considered dubious and not diagnostic of ischemia. A MIBI SPECT was performed and demonstrated no clear ischemia, and also a CTCA was performed and it showed no obstructive lesion. And remember, the negative predictive value of a CTCA is incredibly high. In this particular case, they went on and performed a pressure wire assessment. And here they have taken a measurement and it is clearly showing a period of rest followed by a period of hyperemia. If we look at the resting segment, which is shown on the left part of the pressure trace, there is perhaps only a very trivial resting gradient. However, once the hyperemic agent is given, there is a very marked separation of both proximal and distal pressures, causing a very large hyperemic ratio or FFR of 0.61. If we look at this on face value, we may think that this is a situation where multiple non-invasive investigations in a patient who has very atypical symptoms have got it wrong, and that an invasive investigation by FFR was able to identify a ischemic causing lesion. Some may also say that a pressure index measured at rest would have missed this lesion because no apparent gradient was seen, and that it is only by giving hyperemia that we were able to generate such a large gradient. However, if we reflect back on what we discussed, where large increases in flow, and therefore by definition non-flow limiting vessels or lesions, can cause a large pressure loss, perhaps we can think that this is an example of this exact situation. If we look at the angiogram, there is no obvious significant stenosis that jumps out at us, and there are a number of investigations here that we have typically used as gold standards in the past, including MIBI. And while CTCA reporting will always vary from different institutions, I would say it is quite a challenge for a CTCA to be reported as entirely normal, and when they are, if they have an excellent negative predictive value. So what could be happening here? It could be that this is a situation where there is a trivial stenosis and there is a large response to the hyperemic agent such that flow is increasing significantly. If we look at this data here presented by Niels Johnson and Lance Gould from Texas, we can see that fractional flow reserve is known to have a limited relationship with CFR, a flow-based index of whether a vessel is important or not. If we look here, the data can be divided into quadrants, and in this elegant paper, Niels Johnson demonstrated that fractional flow reserve has only a 60% match with CFR. Let's go through the quadrants in turn. In this quadrant here, we can see that there is normal flow, but an abnormal FFR. Here we can see that the individual is able to generate flow that is sometimes 3 or even 4, and in some cases up to 4.5 times higher than their resting state. And the FFR is coming out as being positive or ischemic. So this is an unusual situation. This is a situation where the flow is saying that there is no problem and giving a hyperemic agent causes a large escalation in flow, but the pressure index is saying that there is ischemia. When considering this, one should remember that FFR, or fractional flow reserve, is a pressure-based index that is attempting to estimate flow. It is not measuring flow directly, and it is only creating an estimate of flow if lots of different conditions are perfectly met each time. Here in this lower quadrant on the right side, we have situations where flow is abnormal, but the FFR value is coming out as being normal. So in this situation, the flow is falling in response to adenosine or another hyperemic index, such that the CFR is becoming less than 2, but the FFR is higher than the 0.80 threshold. This may well be due to a microcirculatory disease and may represent a different disease entity. So we can see that there are two very distinct groups in which pressure and flow are not closely related. Here we have an example from our own cath lab in which a patient was undergoing an assessment using a combo wire. This is a wire that allows you to make both pressure assessment as well as making a measurement of flow velocity. Here you can see along the top a typical pressure trace. We can see that pressure is nice and stable in the resting state. Adenosine is started using 140 micrograms of adenosine per kilo per minute, and we can see we have a period of stable hyperemia. In the rest, the PDPA, or the resting ratio, is 0.96. The iFR, which is the instantaneous wave-free ratio, is 0.93. When we've given hyperemia, the stable hyperemic pressure ratio is 0.79. So here, these values appear to be in conflict. The iFR is above its threshold for intervention, which would suggest a value of 0.89 would require stenting. Above 0.89, so i.e. 0.90, we would defer. But here on the pressure ratio, or under hyperemia, we're seeing that an FFR value of 0.79, so that's suggesting we stent. If we then measure flow velocity, we can see in this case here that the flow velocity goes up significantly. So the flow velocity is nice and stable, and you can see that we have a very good traces here. And during the stable hyperemic period, we have a very significant increase in flow, such that, in fact, there's a 350% increase, or a CFR of 3.5. So in this situation, the pressure is saying that we should be stenting if you're following the FFR, but the flow is saying defer. That is, the flow is more than adequate and can raise significantly with hyperemia and therefore cannot be flow limiting. If we look at the console screen, this is from the combo map system itself. We can see that the FFR is 0.79, we can see the CFR is 3.5, but we also have a number of other parameters here. Here we have also the HSR, the hyperemic stenosis resistance, which was developed by Jan Peek at the Amsterdam Medical Center. This is 0.24. Now, for those of you who are not familiar with HSR, a value of over 0.8 would be considered ischemic. So values below 0.8 are not considered ischemic. So it can be seen here that the HSR, which is calculated by using the transstenotic pressure gradient divided by the hyperemic flow, so it's a combination of both pressure and flow, is agreeing with the overall flow that there is no flow limitation in this particular stenosis. What is interesting, however, is that the resting index was negative and suggested that no stent was required. On a head-to-head comparison, one would assume that the resting index, such as iFR, was incorrect if you were comparing it to a standard such as FFR. But when we compare it to measures of flow, we can see that perhaps it is a fractional flow reserve that is incorrect. Does this matter? And what do the clinical studies tell us about it? Well, unfortunately, we don't have a lot of the data from the FAME or FAME2 studies in which we might be able to get a clinical signal of whether a resting index and pressure index, hyperemic index was related to outcomes at all. But we do have some excellent data collected by Jan Peek, and which was presented by Tim van der Hoof and has now recently been published, in which they were very brave and made both pressure and flow assessments in stenoses and managed them according to the flow and not the pressure. What is also unique about this study is that they have phenomenal follow-up data out to 10 years, giving us a real insight of what happens to these patients if they are managed in this way. First, if we have a look at this blue line, we can see here are the patients who are both fractional flow reserve negative and also had a normal CFR. we can see that over 10 years, about 25% of patients would have had an accumulative MACE event. So this is MACE as defined typically with myocardial infarction, cardiovascular death, or revascularization. Perhaps what is more pertinent is to looking at the first 2 or 5 years, which would show what we would expect in the near-term future for our patients. We can see that follow-up event rates were approximately 10% out to 5 years. If we look at another cohort of patients in which the FFR was negative, but the CFR was abnormal, that means the fractional flow reserve was above the 0.8 threshold, so no stent was deployed, but the CFR was abnormal, we can see a huge event rate, and that event rate separates incredibly early and is profoundly significant. We can see that these patients have a lot of events. Clearly, within this group, there may well be a number of patients who have microvascular disease and therefore have an abnormal CFR with an apparently normal FFR. And it really highlights that using a pressure index alone is not necessarily sufficient to be able to know what the best outcome for a particular patient is going to be. But what about these patients with an important discrepancy? These are patients that have a positive FFR, that is, FFR says this is ischemic, but the flow-based index is saying that there is no flow limitation, so the CFR is normal. Well, as you can see plotted out to 4 years here, there is no significant difference between those patients and those with a negative FFR and a normal flow. So whilst these patients have a positive FFR, they behave very similar to those patients with a normal flow pattern. And this non-significant difference follows through out to 10 years. So perhaps whilst this is a clinical study and a lot more work is required, we can begin to see that these patients that have apparent ischemia on a FFR measurement but have normal flow actually have good outcomes if they are deferred. Well, okay, you may ask. You may say, well, I only have access to pressure-only technology in my cath lab. How can I identify these patients? Well, it is actually now possible using essentially a pressure-only approach. If we look at this information from a paper that's now published by Petracco et al., it shows the relationship between iFR and FFR and what the individual CFRs were. So in this particular study, iFRs were measured and compared to FFR, but also in these patients, a CFR was measured invasively. And we can see that there is a good relationship between the iFR and FFR. But if we look in the segment that would traditionally be considered as iFR making a wrong diagnosis, that is an iFR that is negative, or and with an FFR that is positive, if we zoom in on that quadrant and we look at the panel on the right-hand side, we can see that all of these dots are green in terms of their flow. Each individual case has had a high CFR, a CFR of over 3 in many of these cases. And it is this work that showed that a resting index, iFR, has a better relationship with hyperaemic flow than fractional flow reserve. And therefore we can surmise that if we have a situation in which the resting index, such as iFR, is negative, but the fractional flow reserve is positive, that there may well be a situation of increased high flow velocity driving a pressure gradient across an otherwise non-significant stenosis. This means that we have a way of identifying these cases in the cath lab now. If we have a situation in which the resting index is very negative, but the hyperaemic index is positive, then one should consider the possibility of a high flow situation driving a significant pressure gradient, as first described by Gould in 1978. This area is certainly of great importance, and Niels Johnson and his colleagues from Texas are currently preparing a study called the Defined Flow Study, specifically to look at the outcomes of these patients in which flow and fractional flow reserve disagree with each other. And this is clearly an important area of research in the future. And here we're showing the ROC curves of the relationship between iFR and FFR with CFR. And we can see that the ROC coefficient for iFR is significantly greater than the ROC coefficient for FFR. And if we constrain the data to look at what is considered the physiologically important range between 0.69 and 0.90 on the FFR scale, then we can see that significant difference between iFR with flow versus FFR with flow continues to be present. How can we match the findings of iFR and FFR in current practice before we find out the results of these studies? Well, there's some important data from the FAME2 study. You can see that actually the vast majority of discrepancies between iFR and FFR tend to be very, very small differences very close to the threshold. For example, an iFR value might be 0.91 and the FFR might be 0.80. On a pure dichotomy scale, we can see that the iFR would be considered as being negative and the FFR as being positive, but we know that there is a significant measurement variability that can occur with any index, and therefore if you repeated the measures 10 minutes apart or even later, perhaps under different conditions, these values may be slightly different. For example, we know from the DEFER study performed by the founders of FFR and experts in the technology, when they repeated FFR 10 minutes apart in the same patient, the same lesion with the same wire and the same hyperemic stimulus, they found that there was a 15% chance of classification change. So 1 in 6 patients would have switched from stent to no stent or vice versa. So these things can happen, and some of this will account for any apparent discrepancy. Does this make a difference from a clinical point of view? Well, if we look at the FAME2 data, we can see that very, very few events actually occurred close to the threshold. So if we look at the patients who were classified as 0.81 on the FFR scale and above, then the number of events that they accounted for in the FAME2 study were only 3.9%. Similarly, if we are just below the 0.80 threshold, we can see that the number of events are 8.1%, with the majority of important events occurring when FFR values are much lower, below 0.70. This is actually also borne out in an important analysis conducted by Niels Johnson, in which all the world's outcome data from fractional flow reserve was assessed in a complex meta-regression analysis, and he found that the FFR value most strongly associated with clinical outcomes was 0.67. The take-home from that is that borderline lesions with borderline physiological values tend to have low numbers of events. So to round things up, we have looked at what causes iFR and FFR misclassification, and we've considered whether these differences are important. Clearly there will be situations in which one technology will say stent or not stent, but we've now reflected on reasons why that may happen. It appears that iFR, the instantaneous wave-free ratio, is more closely related to flow-based indices, and we can see that there are situations when the iFR is negative and the FFR is positive, but that can be because flow is very high and normal, and therefore the instantaneous wave-free ratio is perhaps correct. Certainly in these patients, if when flow is normal and the FFR is negative, if they are deferred, they have a low number of events and are generally very safe. Finally, there are situations in which the iFR can be positive and the FFR is negative. This has occurred consistently throughout many of the different studies and has occurred within the ADVISE study, the ADVISE registry, in the iFR pre-post study. These are cases where the iFR suggests a stent should be deployed and an FFR is negative. This does happen more commonly than the presence of a negative iFR and a positive FFR. And since we expect iFR to be more closely related to flow, we would assume that these are situations in which the CFR or flow is abnormal, and we know that these cases have a very high event rate. So there is a suggestion that these patients with a positive iFR and a negative FFR would be better off having some form of intervention rather than being deferred. Future studies are awaited to confirm this.